Today we will illustrate 4 stories that showcase our ability to fulfill our mission, which is to help patients and families live better through end of life. As we begin, and if you want to reference your sheet, I want to give you 4 key takeaways to remember and to keep in mind as we discuss these stories. First, anyone can make a hospice referral at any time. Secondly, we try our best to get a member of our team out to meet with patients and families within 24 hours of receiving phone calls. We will see anyone, anywhere within our service area, and we really treat every patient and family as individuals because every situation is different. Number 3, we offer our services to anyone regardless of their ability to pay. And number 4, we collaborate with equipment companies and pharmacies to ensure patients and families get what they need as quickly and seamlessly as possible, and that's across all the settings in which we serve. Our first story is about a telephone call that we received from a social worker in a nursing facility in Elizabethtown. She recently met with a resident named Jane and her family, and they're concerned about her mother's decline in health due to her dementia. In talking with the patient and the family, the social worker decided to have them call hospice.
So I am the team leader of the Access Department, and if you don't know what that means I oversee the team of nurses that come out to wherever the patient is at so that we can do that referral and assessment and admit them to the hospice service. So we're typically the first face the families and patients see of hospice. So we did receive the referral from the social worker. We called the family at that time, and then we set up an appointment that worked well with everybody and met the family and the patient at the nursing home in Elizabethtown. Our nurse was able to do the assessment and determined through collaboration with the family and the patient what their goals are, and the patient was deemed appropriate for hospice services. So part of what our nurses do for that job is to talk to the family about what's been going on with the patient as far as her physical decline related to her dementia. We do a physical assessment, actually hands-on, heart, lungs, the whole physical assessment piece. We discuss how we are able to work with the nursing home and with the patient and the families so that they can get adequate hospice care. During the discussions, we found out that this patient had been a member of the military. She's a veteran, and for our veterans, we have a lot of special programs. We want to honor them for the service that they provided to our country. And we arranged to have one of our volunteers go out to the facility so that they could do a pinning and present the patient and the family with some certificates in appreciation for what they were able to provide. Specifically for our patient with dementia, we found that a lot of those folks, I don't know how many of you are familiar with patients with dementia, but a lot of them feel like they need to have a purpose. And we don't know what that purpose is, but we provide, if you look on the table in the back, we have cats and dogs that are actually provided from funds that are provided from the Women's Giving Circle. A lot of our folks are used to having pets when they were independent in their own home. These cats will purr or bark, they will roll over, they shake their heads, and a lot of our folks will just sit and hold those dogs and cats. It gives them a purpose, it gives them a feeling of being wanted and needed. We also provide folks that are specially trained in patients with dementia care, and we help instruct and oversee the care that's given so that their care is specific to a dementia patient. A lot of folks have different presentations with dementia, they have different behaviors, and we kind of make sure that those behaviors are controlled, but the behaviors can be directed into a productive pattern so that everybody is comfortable.
So as Director of Finance, I oversee our patient accounts department, and while community care has an overall mission of making sure that people have access to hospice care and support and services regardless of ability to pay. Our patient accounts department and finance department actually has a secondary goal, and that is to help kind of navigate those insurance benefits, take some of that complexity away from the patient and family, carry some of that burden, and minimize and hopefully eliminate any surprise financial expectations after the fact, or denials of coverage, anything like that. So we're constantly working behind the scenes with the insurances to make sure that we're finding and identifying all of the resources that might be available to help cover the costs for patients and families, and then navigating all of the administrative work that goes along with that. In Jane's situation, for this patient, she was a Medicare beneficiary, and so she had the Medicare hospice benefit available to cover the cost of her hospice care. Under the Medicare hospice benefit, Medicare provides full coverage for hospice services across all settings, including homes, hospitals, and nursing homes. And under the Medicare hospice benefit, Jane would actually have no deductibles, no co-insurance amounts, or out-of-pocket expenses, because Medicare does pay for hospice services 100%. Additionally, under the Medicare hospice benefit, all medical services that Jane may need that have been determined to be related to her terminal illness become our responsibility as the hospice to not only coordinate and authorize, but also pay for on behalf of Jane. When she needs those additional items, they can include anything like medications, or supplies, or even durable medical equipment. Those are kind of services that go beyond our team visits that are provided to patients as well. If a Medicare beneficiary requires those additional services from an outside provider like a pharmacy or a community supplier, then we will work with and coordinate to authorize those services to those providers, as well as get payment to them on behalf of the patient.
From the clinical support end, getting down to the nitty-gritty of, so how does this really happen? We have a team of folks that work very closely with the care delivery people in those facilities to assure that the patient has what they need. We work very closely with the members of those skilled nursing facilities and personal care homes, so that we're coordinating with their staff, with their equipment companies, with their pharmacies. And each facility is unique. Each has a different approach to care, and we work to tailor our care to meet the patient need while we're directing the care with the facility. In Jane's case, she needed oxygen, so that came through our contracted provider. In Jane's case, she also didn't want to stay in her room or stay in bed all the time, but she really couldn't sit in a regular chair. It wasn't safe. She liked to get around on her own. And one way we were able to help that was to get her a special chair called a Broda chair. Some of you may be familiar with that. But this also had the ability for her to pedal. So again, that purposeful part of being able to pedal around the hallway and visit sometimes when she shouldn't, but she was able to get out and enjoy some of the environment that she was in. She did enjoy her cat, and the cat would ride along with her. In our skilled facilities, we have to respect that there are unique challenges with the staff, and so we work very closely to help educate what hospice is and what our hospice medications might look like, because it is a specialty in end-of-life care that some folks just don't have the opportunity to learn in their other careers. And so we have the role and a tremendous opportunity to educate, and we do that each and every time we're there.
Our second story is about a telephone call we received from an Amish family that lives in Bird in Hand for their 75-year-old mother, whose name is Fanny, who has heart failure. Because we cared for other members of the family in the past, they were comfortable with hospice and community care and decided to call us again.
So we did receive a phone call from Fanny's son, Samuel. Samuel and his wife take care of Fanny in their home, as do many of our Amish folks that we take care of. They had another family member on services. They noticed that Fanny was having a decline in her health due to her heart failure, and they weren't quite sure where to turn for assistance, so they called us to see how we could help. So we set up an appointment. We went down to Birmingham and we met with the family. We met with Fanny. We discussed what hospice services would look like. We did our physical assessment, and in talking to the family, collaborating with the patient's family doctor, and with our physical assessment, we determined that Fanny is declining in her health. However, she wasn't declining to the point where she was quite ready for hospice services yet. So it's a little delicate conversation sometimes with people that really do want us, but our patients need to meet certain criteria. Luckily, we have a program, it's kind of a bridge program to hospice. It's called our supportive care program. It's for folks that aren't quite ready in their physical state to sign on to hospice, but we've noticed that they could benefit from some of our services with our supportive care program. So we were able to offer that to Fanny and her family.
So our supportive care program is an innovative program. It's a little bit unique to hospice and community care. Because it is innovative, while that's fantastic, it also means it's working ahead of the insurance industry. So therefore, there really are currently no private insurance carriers that offer any kind of benefit or coverage for supportive care. That means every patient that admits to our supportive care program is coming to us as a private pay individual who would be responsible to pay for the individual medical visits that are provided by our interdisciplinary team members. It also means, however, that every patient admitted to supportive care can be assessed for eligibility in our charitable care program. And this is where community donations, special endowment funds, and other specially designated grants, such as our Dementia and the Women's Giving Circle heart failure grant, can be used to cover the patient's costs when the patient themselves can't afford those costs. Eligibility for our charitable care program is pretty simple. We really ask for only 2 pieces of information. We request the patient's annual income and the number of household dependents. From those 2 pieces of information, we can establish what we call an out-of-pocket maximum expense. And that is the amount that the individual would be responsible for visits that have been provided to them. And it usually ranges, when we assess an out-of-pocket expense, from $0 to about $2,500, depending on the income level and the number of dependents in the household. And the way it works through our billing then is each visit is billed as they are performed up until that maximum out-of-pocket expense is met or satisfied. After the out-of-pocket expense is met, it is community donations, special endowment funds, and specially designated funds that are used to cover or subsidize the cost of that patient's care. At that point, the patient has no further personal financial responsibility, but our services and support can and do continue seamlessly without interruption. It's simply that it is the community resources, the special endowment funds, or even the grants that are help covering the costs rather than the individual paying for them personally. Our charitable care program and support are vitally important to our patients with limited financial resources, and Fanny actually was a perfect example who fit this particular model. Fanny was determined to be eligible and fully covered by our charitable care resources, and because she was eligible for full charitable care and her illness was due to a heart condition, actually the entire cost of Fanny's stay in our supportive care program was covered by the funds provided by all of you through the Women's Giving Circle Heart Failure Fund. The other important thing to note is that only our interdisciplinary team member visits are covered by charitable resources. So in cases like Fanny, if she needed additional supplies or special equipment, our patient accounts department would work very closely with our clinical support team to identify other resources, maybe donated equipment, or even pharmacy gift cards, again, funded through the Women's Giving Circle, that would help provide those additional services to the patient and to Fanny when she needed them.
This is the art and creativity coming into play. For someone who doesn't have resource or has very limited resource, or perhaps is on supportive care, it doesn't mean that they don't have tremendous needs. And we look to all of the folks on the team to help come up with solutions. That could be our storage closet, if you will, that's maintained by our equipment vendor of donated pieces of equipment. And that's everything from walkers to wheelchairs to hospital beds. In Fanny's case, she's Amish. They don't have electricity in most cases. Doesn't mean that she wouldn't benefit from a hospital bed, so it means that we provide one that's a crank bed. And that was tremendously helpful in being able to help her be more comfortable when she was trying to lay down to sleep because she could not lay flat. So that was very helpful for her. Other folks that maybe are not Amish, where else could we get things? Sometimes the VFW, the American Legion, sometimes faith communities have storage closets of other equipment. So we do use those other community resources to help support our patients and families. The Amish community is very much involved with hospice. They believe in allowing nature to take its course and allow disease progression as it is typically expected, and allow a natural death. We help walk that path with them. They're also often interested in alternative therapies, and that can be herbal kinds of things, special wound products that are really just leaves and mustard and what have you, kinds of homegrown, but very often very effective modalities. It is not our job to tell them that it isn't acceptable, but rather to walk that path with them, work with them, identify what's working and isn't, and when they've been taking a whole slew of interesting, non-traditional or traditional medications, if they're not helping any longer, suggest that maybe this isn't necessary and isn't helpful, and let's make it a little easier. That applies for all of our patients every day.
Our third story is about a telephone call we received from a physician who works at a cancer center in Lancaster. He's supporting a 45-year-old gentleman named Chris, who has cancer. During a recent visit, this physician told Chris and his family that his cancer treatments are no longer effective and that it's likely time for hospice. Because Chris has a wife and children, the physician also said it could be beneficial for hospice to be supportive not only to Chris but to his family as well.
So again, the Access Department received the referral from the Cancer Center. We set up a time to meet with Chris and his wife. They preferred to meet at their home at a time when their children were in school. They did relate to our nurse that went out that his children were aware that he has this terminal illness, but they didn't really want to discuss all these hospice details while their children were home. So we met at their home and we did discuss what hospice looks like and how we can help take care of him and his family. With all patients, the patient isn't our only responsibility. By default, the family becomes our responsibility as well, and they become our patient as well. Our nurse did note that one of the children had been having problems in school since Dad's diagnosis, and I thought it may be related to how this child is dealing with that. So we were able to make an early referral for what we call anticipated grief through our Pathway Center up in Mount Joy. so that we could start doing some counseling and some discussions with these children to help them try to understand, who none of us can really understand, but try to understand and how to cope in a healthy manner with what's going on with Dad. Chris and his wife also revealed to our nurse that they really, when it came time for Chris to pass away, they would prefer that not happen in the home. Chris said that he was very concerned that he didn't want his children to remember their family home as where Dad passed away. So we had a lot of discussions about what that looks like going to our inpatient center up in Mountjoy.
Since Chris was only 45 years old, he was not eligible for Medicare, so he did not have the Medicare hospice benefit available to help cover the cost of his services. He did, however, have a private insurance policy through his employer. Almost all private insurance policies now do offer some kind of hospice benefit and coverage, but how it works is frequently, almost always, customized according to the employer's specific plan design. And it's also very common within private insurance policies that case management and pre-authorization for service requirements are in place in order for the benefit to actually cover services. So what we do within the patient accounts department for every private insurance patient admitting to our program is we place a call to the insurance company directly. We have a pretty extensive list of questions we ask. We get all of the detail and customized benefit information we can from that insurance carrier, all of the case management requirements as well as authorization requirements. And we actually log that information in this case, in Chris's electronic medical record. We log that information in the electronic medical record so that all of our staff members, anyone who may be providing care to Chris or another private insurance patient, will have the specific information available literally at their fingertips. It's readily available and accessible within the patient's chart, and they can see if there's a quick change needed in service or the level of care being provided. They'll know right away what requirements need to happen with the insurance company to allow the policy to put the proper coverages in place. In Chris's case, he actually needed a general inpatient stay in our inpatient unit. So the general inpatient level of care is a higher level of service that hospice can provide. We do that through our inpatient unit. And it's basically for those patients who may be having pain or an uncontrolled symptom issue that just can't be managed in the home or residential setting. So for those patients, and for Chris in this situation, we have the inpatient unit available. They can come to the inpatient unit where they have access to medical and even social work support 24 hours a day, 7 days a week. It's for those cases where maybe we need to monitor changes in medication levels, whatever it takes to get that symptom or that issue under control and get the patient back to a level of acceptable comfort. In Chris's case, when we had called to verify his insurance coverages, the plan stated to us that he actually had a specific authorization requirement only for the general inpatient level of care for hospice. So at the point where Chris needed that specific level of care, we knew up front that we would have to call and get authorization from the insurance company in order to have his costs in the inpatient unit covered by his insurance. And patient accounts was able to communicate that information with the inpatient team leader who made that call and was able to get the authorization in place for Chris before he arrived at the unit. So that would be one less worry for Chris and his family. The other piece of information the insurance company communicated was that there was a $500 deductible on Chris's plan that had not been satisfied. So that would be a personal responsibility, financial responsibility of Chris and his family. And when we are given information of that nature, specifically with private insurance patients, our patient accounts department will also prepare letters after we have done benefit verifications, where we summarize all of that special information in a letter back to the patient and family so they have it for their own records and they know later they're not surprised by an unexpected expense.
We certainly strive to make sure that every patient at home is as comfortable as they can be. Managing symptoms is part of everything that we do. That could be pain, that could be seizures, that could be shortness of breath, and a host of other kinds of things that are not uncommon that we deal with every day. When we're struggling to get symptoms managed, we're working closely with our physicians and our nurse practitioners, and they may make a visit to take a look at the patient as well. In this particular case, we maximized what we could do at home. And it's stressful for the patient, but also distressing to the family. So it was important to come to the inpatient unit to get symptoms managed. There are a lot of myths out there about the inpatient unit. Some folks think that going there means you're going to die. Other folks think you can go there and live there. Because it's a really very nice place. The intent there is, in his case, while he did not want to be dying at home, it's not uncommon to go to the inpatient unit, have symptoms managed, and go back home. Doesn't mean that once you've had one time that you're limited to one trip. You can come back. If symptoms need to be managed and addressed again more aggressively, or in his case, when it looked like death was coming near. Private insurance does not cover ambulance transport in most cases. And the financial burden, because of the deductible in Chris's case, was very difficult. Young families with children, and often have been two income families, are really struggling when you're hitting this point in time. So we were really fortunate to be able to use Women's Giving Circle funds for the ambulance transport, for him to be able to be transported comfortably to the inpatient unit. The transfer to the inpatient unit is one of the singularly most significant impacts during a hospice patient and family's time with us, because of those myths, because of the deterioration in condition. Family can visit 24/7. We can provide support. They can bring the household pet along as long as they're well behaved and restrained. Our goal is to maximize support and comfort. Chaplain is there, social worker, medical, and nursing personnel 24/7 to be or are available if not on site. The inpatient unit is something that is unique to most hospices, and we are tremendously fortunate at the support of the community that has been able to support keeping our unit and building it to be the facility that it is. It really is something special.
Our final story is about an electronic referral we received on the computer from a nurse at a children's hospital in Philadelphia. She is discharging a 4-year-old boy who lives in Ephrata. His name is Billy, and he'll be leaving the hospital later this week, and the nurse thinks that Billy could benefit from hospice services at home due to his life expectancy of 6 months or less because of a brain tumor.
So, like Colleen said, the Access Department received this electronic referral from the folks at a Philadelphia Children's Hospital regarding this patient. Oh boy, 4-year-old with cancer. This is something that nobody wants to live through, nobody wants to deal with, nobody wants to have any part of. However, we do. We're blessed to have a very good pediatric team at Hospice and Community Care. We have special team members on all disciplines that are trained in pediatric care. That would be all the nursing, all the nurses' aides, our social workers, and our chaplains are all specially trained in pediatrics. We also have a large core of volunteers that have taken some special training as well to help our families. Excuse me. So we did receive this referral by the computer, and Billy is still hospitalized, and he's going to have some special needs that need to be in place in the home before he can come home. So our access nurses had been in contact with the social workers down at CHOP. We've been in contact with the palliative care team down at CHOP, and with the parents themselves, so that we can make some arrangements and get some basic information so that we're prepared when he does come home. We have a specially trained nurse. Her name is Pam Acey, and she is our case manager for all of our pediatric patients. She has a heart for hospice and an even bigger heart for our pediatric patients. She will see and admit all of our hospice patients that are pediatric age, obviously, that's up to age 18. She goes to the home, very graciously gets a history and does an assessment of the patient's physical condition, but she's also looking at what else is going on in the home. Again, Billy is not our only patient. We have two parents here that are facing the prospect of losing a 4-year-old child, and there are also other children in the home. How do we help deal with that? And again, we do have that whole team of folks that are specially trained to help with that aspect. But from the generosity of the folks here at the Women's Giving Circle, we have a lot of memory-making kits that we use for our patients. Some of our folks have shadow boxes where we'll put together for our babies, clips of hair and their nightgowns that they're wearing. We have some families that have made shadow boxes that have handprints of all the family members. We have another kind of kit that is really very special, where all of the family members will put their hand into a mold, and we'll actually have everybody's hand in plaster as a memory for these folks for when their child passes away. Talked about our volunteers. Our volunteers come in real handy because mom and dad are taking care of this sick and failing child, but they also have responsibilities too that they need to attend to. So we do have our volunteers that are trained that will come into the home just to kind of provide some companionship and oversight with the other children, with Billy himself, so the parents can tend to the errands that they need to run.
So due to their extreme young age, our pediatric patients often have multiple sources of insurance coverage available, but each has to be coordinated and managed in a specific order of coverage priority. And for Billy, there was a private insurance policy available for coverage for hospice services, and he also had a Medicaid managed care plan available covering hospice services as well. So not only were there multiple benefits to coordinate, there were also multiple layers of case management to navigate. For example, the private insurance carrier required authorization for hospice services and case management. So at Billy's admission, we had to make sure we had those authorizations in place with the private insurance company, but the Medicaid managed care plan also had case management authorizations required. So even though we already had the authorizations with the primary coverage through the private insurance, we had to go through the whole process again with the Medicaid managed care plan and get authorizations established through their systems as well to make sure we were maximizing all of the benefits that were available for Billy. Fortunately for Billy, Medicaid offers a special, it's actually a legislated expanded coverage known as Concurrent Care. And under the Concurrent Care legislation, Medicaid plans can actually provide coverage specifically to pediatric patients that allows coverage for both curative and aggressive treatments simultaneously while the pediatric patient is receiving hospice care. For an average age hospice patient, that would not be available. Generally, patients admitting to our hospice services are electing to use a plan of care focused more on comfort measures, not on curative measures, and they're foregoing the aggressive treatments in order to let their hospice coverages pay for hospice services. In Billy's case, because he was pediatric and the concurrent care laws were in place, he was actually able to continue to pursue some what would normally be considered aggressive treatments while he was receiving hospice services. So that was a huge benefit to both Billy and his family. Even though with multiple insurance coverages, illnesses like Billy's can present some major financial hardships, especially for young families. making it difficult to do simple things like paying the everyday bills or buying groceries. And when Billy's parents were struggling to buy groceries, we were fortunate enough to have the grocery store gift cards that had been provided through the Women's Giving Circle funding to offer to his parents to help at least ease that burden.
As you can tell, our pediatric population plucks at our heartstrings for each of us in a different way. It also stretches our ability to coordinate because, just as Becky described, it's the financial pieces, but all of the pieces that go along with what is involved in dealing with a pediatric patient. It is not unusual for them to have a host of different equipment needs and many pieces that are already in play in the home. Their medications may look very different doses, different modes, different ways of administering medications. We work very closely, and our medical team is very closely involved with our pediatric patients so that their symptoms are well managed, so that we are able to anticipate needs, because each of these kids is different. One of the challenges for the pediatric family is mom and dad have been tremendous caregivers for sometimes a long time and sometimes not long at all. They're taking care of tremendous clinical needs, tube feedings, ventilators, all kinds of special high-tech equipment. They're specialists in their child, and we learn an awful lot from them. They're carrying that burden every day, and willingly so. When things start to deteriorate, as we would expect, our role is to walk with them, make sure that we're supporting them, that we're able to anticipate and provide for the medications and other treatments that will help keep Billy as comfortable as possible. Often, our pediatric patients are seen by our complementary therapy folks. This particular population of patients, the pediatrics, really do well with massage as a way of helping ease and comfort and reduce their discomfort from just the tension of being ill. In addition, our music therapy really, as I said, plucks at their heartstrings, but this is different. They may become, depending on the age of the child and the other kids in the home, they can be actively engaged together, making music. And this can be drumming, it could be guitar, it could be using the iPads to create their own music, and just playing the kind of music that Billy was most appreciated. They do a tremendous job in connecting with kids in a different way than any of the rest of us can. And we're very thankful to have them. One of the other things that we typically will see, as I said, the parents are experts. This is what is normal for them in a household with a terminally ill or chronically ill child is so very different than the normal that most of us are accustomed to. When things really start to change, we're trying to help them know that it's okay to just be parents again, and that we're there to help take on some of those burdens of providing the care. When things are really difficult and symptoms are changing actively, mom and dad need to be mom and dad, and sometimes, and keep an eye on the other kids. We may consider our continuous home care, which is think of it as private duty, one-to-one, nursing in the home to help support and assure that those needs for Billy and his family are met as well as we possibly can. It's a challenge, and we feel fortunate that we are able to be engaged at this point.
As you can see, every day at Hospice and Community Care is very, very different. But the common theme across all of these stories is our ability to fulfill our mission, which is to help our patients and their families live better through end of life. And really that's what it's all about. So we will now take your questions.